Good morning, everyone. We will begin our webinar shortly. Good morning and welcome to all the attendees. We'll give it about another 1 minute or so, and then we'll start the webinar. Okay. Good morning and welcome to SAHPRA's webinar on World Malaria Day. I'm Taonga Chilalika, Advocacy Officer at PATH, and I'm pleased to be your moderator for the day. Thank you for joining us. According to the National Institute of Communicable Diseases, malaria is a potentially life-threatening disease caused by blood parasites, which are transmitted via the bites of infected mosquitoes. It is, however, curable and preventable. Once in the body, the parasites multiply in the liver and then infect and destroy red blood cells, causing symptoms such as fever, chills, headaches, as well as flu-like illness. Malaria is also a major world health problem, particularly in sub-Saharan Africa, where it is responsible for a significant number of deaths each year, especially among children under the age of 5. In the past few years, between 2015 and 2019, South Africa has had between 10,000 to 30,000 notified cases of malaria per year, and the National Department of Health is planning to eliminate, in other words, no local transmission by this year. The malaria situation in South Africa can also be explained by referring to the Elimination 8, which is a coalition of 8 Southern African countries, better known as the E8, working across national borders to eliminate malaria by 2030. South Africa is one of the 4 frontline E8 countries earmarked to eliminate malaria by 2025. In today's webinar, over the next 90 minutes, we would like to focus on understanding the basics of what malaria is, knowing when a person has malaria, preventing malaria, as well as current research and findings around clinical trials and vaccines that are currently underway, and also South Africa's role within the E8. Please feel free to join this conversation with us on social media by using the hashtags Malaria Webinar, Unpacking Malaria, World Malaria Day, and Malaria, as well as Malaria. And please feel free to tag at SAHPRA1. For anyone that would like to pose questions to our speakers, we kindly request that you make use of the Q&A function to ask any questions that you might have to our speakers, and we'll be able to get to those questions towards the end of our 90 minutes. Please join me in welcoming our first speaker for today. I'd like to introduce Mr. Dion Puvan, who is a Senior Manager for Inspectorate and Regulatory Compliance at SAHPRA. Mr. Dion will give us an overview of SAHPRA's regulatory processes related to malaria. Mr. Dion, over to you. Thanks.
Thank you so much, and welcome to all the attendees here today at the webinar. I just want to confirm if you can see my screen.
Yes, we can see your screen.
Thank you. So today we're going to be talking, I'm going to be just giving a few remarks about the overview of SAHPRA and its regulatory processes. As you know, SAHPRA is the South African Health Products Regulatory Authority. and is responsible for monitoring, evaluating, investigating, inspecting, and registering all health products. SAHPRA plays a very important role in determining the controls of the supply chain as well, and also plays an important role in ensuring the availability of medicines that are safe, of quality, and are efficacious. And this applies to the fight in terms of malaria, because the availability of these products and the prevention of any substandard and falsified medicines in the supply chain will ensure that the health system is able to treat cases of malaria and therefore reduce its occurrence. So what do health products entail in terms of SAHPRA's mandate? It's medicines for both human and animal use, medical devices, IVDs, and radiation control. And the examples of some of the regulatory decisions that SAHPRA makes, we do, like, for example, registration of a medicine or a vaccine, which is required before a medicine can be marketed. We also have the approval to conduct a clinical trial in South Africa. That also goes through SAHPRA, as well as the approval of compassionate use of an unregistered medicine, which is done based on motivation to use that unregistered medicine. So these are just some examples of the regulatory decisions we make as SAHPRA. So I'm going to speak specifically about medicines today, as the majority of the treatments for malaria is in the form of medicines. When it comes to medicines registration, just an overview of our medicine registration process. We have got our reception, where we receive dossiers for new products that are registered, or where companies would like to register these products. We receive those dossiers. It then goes through a check by our inspectorate to verify that the sites that are submitted in those dossiers are GMP compliant. If we cannot find evidence of that based on reliance, SAHPRA then also has an inspectorate which is able to go and inspect the sites to determine GMP compliance. And this is to make sure that products are manufactured without any contamination, and that what they put into the product is what they get out in the quantities that is required. The next step in the product new registration application process is the technical evaluation of the data provided. So we have the approval of the name, and also the approval of the scheduling status of the product. We have the evaluation of the chemistry, manufacture, and control aspects of the product. And we also have the evaluation and the approval of clinical data supporting the safety and efficacy of the product. Once all the technical evaluation units have had a look at it and done their approvals, it then goes to our registration committee, where we will decide on the registration of the product, and then we will either reject, or we will provide a certificate of registration for the product. In terms of our post-registration framework, so we don't just leave it at the point of registration. We've got lifecycle management, where we review and approve amendments to products and licenses. We've got post-market surveillance testing, where we sample and test across the supply chain based on risk. We've also got pharmacovigilance, where we monitor the safety of health products to better detect and understand adverse events. And also SAHPRA is able to perform recalls and withdrawals and initiate market action where we find that a product does not meet requirements or is of a public safety concern. As I've mentioned, we do have a process for approving unregistered products, and this allows for access to unregistered medicines, but on a named patient basis. We may also use this process to facilitate the use of medicines in a public health emergency situation, but we as the authority decide what is required for an unregistered medicine to be authorized for use. This is a very important aspect of unregistered products pathway. We have a clinical trials unit as well, which provides the legal framework for the review of clinical trials and bioequivalent studies for human participants. This unit provides for the authorization also of unregistered medicine for the purpose of conducting clinical trials. They also approve any amendments to clinical trials, and we also request that or require that clinical trials are conducted as per the South African Good Clinical Practice Guideline and other SAHPRA guidelines. In terms of the control of our supply chain, we also license establishments to manufacture, wholesale, distribute, import, or export medicines, medical devices, scheduled substance, or IVDs. And the issuing of this license is subject to the company or the site assuring good principles of manufacturing as well as distribution practices. We have an inspectorate as well, who does inspections according to good manufacturing, wholesaling, clinical, and pharmacovigilance practice. And then in terms of the control of the supply chain, as I've mentioned, the controls in the supply chain prevents and also assists in the detection of substandard and falsified medicines. When it comes to the treatment of malaria, substandard and falsified medicines is a focus area in the Africa region so that we ensure that people do not use substandard or falsified medicines, but rather use medicines that come through the proper channels or the controlled or legitimate supply chain. However, we do, as SAHPRA, we are able to have impact on the illicit supply chain by having jurisdiction in the supply chain. Our inspectors have powers to enter any place that has medicines and health products, and this allows us to enforce the law with other law enforcement agencies to promote compliance to the Medicines Act. One other control that we have in our supply chain is we have specific ports of entries as per our regulation, and we have the ability, as I've mentioned, to initiate recalls and destruction. I hope that this gives a good overview of what SAHPRA does to ensure that medicines that reach the public are safe, of quality, and are efficacious. Thank you very much.
Thank you, Mr. Dion, for sharing that overview and especially for sharing the process that SAHPRA undertakes to ensure safety and effectiveness of medicines, as well as some of the control measures that are put in place for the supply chain, and as well as highlighting some of those cross-entry, cross-border collaborations with law enforcement to prevent the use of substandard and falsified medicines. If you have any questions for Mr. Dion, please feel free to pose those to Mr. Dion in the Q&A. And whilst we do that, I'd like to introduce our next speaker. Our next speaker is Dr. Webby Phiri. Dr. Webby Phiri is the Technical Director for the Program for the Advancement of Malaria Outcomes, better known as PAMO. Dr. Webby will have the opportunity to share on PATH's work in malaria control and elimination, with a special focus on some of the work that PATH is undertaking within Zambia. Dr. Phiri, over to you.
All right, thank you so much, Kaunda, and good morning, everyone. So we'll have a discussion about the path to malaria elimination, both from the global perspective as well as looking at the picture in Zambia, which is one of the Southern African countries and one of the E8 countries. So we'll just have an overview. We'll run through the basics of malaria 101, and then we'll look at some trends and some of the work that's been done in Zambia on malaria, and a note on challenges and opportunities. So the basics, as you might know, malaria is caused by the Plasmodium species, which is carried by the female Anopheles mosquito. And there are 5 species that are known to infect humans. The most famous ones, I think, are Falciparum and Vivax. Falciparum causes
Dr.
the most
Phiri,
deadly.
sorry to interrupt
Yes.
you. Are you sharing slides, or will you be sharing slides?
Oh, yes, I am. Okay. I actually
Sorry,
thought it was.
we're not
Okay,
able to see them yet.
All right, thank you. I hope my slides can be seen now.
Yes, they are now visible. If
All right.
yes, perfect. Thank you.
Thank you, and my apologies for that. I was just sharing. Okay, so there are 5 species that are known to infect humans, and Plasmodium falciparum is the most deadly version of the malaria. So usually the symptoms begin about 10 to 15 days from the time someone gets a bite from the mosquito. And for uncomplicated malaria, the symptoms may be very mild. Some people might actually be asymptomatic, but then most commonly they'll present with a fever, headache, vomiting, and weakness. If it's not treated, malaria can rapidly progress to complicated malaria within 48 hours or so. And it can present with convulsions, frustration, which is a generalized weakness, severe anemia, hypoglycemia, which is low blood sugar, and can go on to cause coma and even death. So The World Malaria Report, which was published by the World Health Organization at the end of last year, gives us a global picture of what is actually happening in terms of malaria. So in 2020, there were 245 million cases of malaria, which slightly dropped to 247 million cases in 2021. The deaths also reduced from 625,000 to 619,000. So generally, the malaria causes around 600,000 deaths every year. And unfortunately, for 2020, which was a bad year for malaria, there were also more deaths, which are thought to have been related to COVID-19 pandemic. But 13 million more deaths could have been caused by the COVID-19 pandemic. The World Health Organization Africa region is home to about 95% of malaria cases and deaths. So this region is mostly made up of sub-Saharan Africa. And children under the age of 5 accounted for about 80% of all the deaths. And 4 countries, Nigeria, Tanzania, DRC, and Niger, accounted for nearly 50% of all the malaria deaths. Regarding progress on malaria in terms of the WHO Africa region, where we have about 95% of the burden of malaria, if you see the trends, in the first decade post-2000, that's from 2000 to 2010, there was quite remarkable progress in terms of malaria incidence, which is shown in blue. There was quite remarkable progress, and the story is the same for malaria mortality. That's the deaths per 100,000 of the population at risk. There was remarkable progress, but once we get to 2015 and moving onwards, as you can see from the graphs, there's actually a stagnation of progress. You can see there isn't as much progress as we had in the first 10 years, and hence the recent discussions about the need for innovations, new ways of doing things, maybe new tools in the toolbox as well. As we go on. So as you can see, by the end of 2021, malaria incidence globally was 229 per 1,000, and we had 58 deaths per 100,000 population at risk. So the world in general has set targets, which is known as the Global Technical Strategy for Malaria 2016 to 2030. So the target, this was adopted by the World Health Assembly in 2015, and there's an update in 2021. And the goals are to reduce malaria incidence by at least 90% by 2030, and reduce mortality by 90% by 2030 as well, and eliminate malaria in at least 35 countries by 2030, preventing a resurgence of malaria in all countries that are malaria-free. And this is nicely illustrated in this graphic, which shows the 3 pillars of the strategy, which is the first pillar is really universal access to malaria prevention, diagnosis, and treatment. The second pillar is to accelerate elimination efforts, especially in areas where there's low burden, to try and get them to malaria-free status. And the third pillar is to transform malaria surveillance into a core intervention for achieving the goals. And these are actually supported by 2 supporting elements. That's harnessing innovation and expanding research, and also strengthening the enabling environment. So most of the country programs for malaria control and elimination work around these pillars. Working with these pillars, as you can see, this graph shows us the progress. What was set, as I mentioned earlier, we are aiming to reduce mortality and incidence by 90% by 2030 as the globe. If you look at the graphs, these 2 graphs show us the progress so far in terms of, if you look at the blue line, the blue line is showing the current estimates of the global incidence. This is from the World Malaria reports. And then you can see that it ends somewhere in 2021, and then there's a projection of the trend. If we continue at the same pace, at the current pace, we continue doing the interventions as we're doing as the world, this is how the progress will go. In green shows us the targets. The targets is what we're actually aiming to achieve according to the Global Technical Strategy for Malaria. And if you can already see by 2021, making a special reference there, we should have been at around 31 cases per 1,000, but then we were at 59 cases per thousand. So in 2021, we're already nearly 50% off track. Similarly, in mortality as well, which is the graph below, we're 50% off track. If the current trend continues, the current rate of programs continues, by the end of 2030, unfortunately, the world might be off track in terms of achieving the targets. You can see we'll nearly be around 90% off track in terms of achieving the targets. I show an article here from the New York Times, which was published in 2018, which was talking about the fight against malaria having reached a standstill and the need for new tools in the box and new innovations. I now move on to talk about Zambia, which is one of the EA countries, as I've mentioned earlier on. You can see in the map, right in the north of the SADC region, we have a population of around 19 million people, and the malaria incidence is nearly 400 per thousand population by the end of 2022. So we're a high burden country. And malaria mortality in Zambia is 6.9 per 100,000 population, and as I mentioned, classified as a high burden. So for the region, it's actually quite good to have a discussion, a focus on Zambia, which is a high burden country, because what happens in Zambia affects the region as a whole. So malaria programs are coordinated by the National Malaria Elimination Center. And I'll go on and show the trends in Zambia. Just like I mentioned the trends earlier on the global perspective, you can see that even here in Zambia, in the last 7 or so years, the trend has also shown the same stagnation. We haven't made remarkable progress against malaria as we did in the first decade post-2000. However, there is a good side of the story in terms of malaria mortality, which is we've noticed a remarkable reduction in the number of deaths per 100,000, beginning off at 25.6 per 100,000 in 2014 and closing off at 6.9 per 100,000 of the population. And we think this is mostly due to improved access to community case management, improved access to testing and treatment, as well as uptake of the malaria-proven interventions. In terms of case fatality rate, again, we see a similar picture like we see on the incidence, the picture of stagnation, again, calling for much more to be done in terms of saving those who actually ultimately get malaria. This is from our recent malaria indicator survey. So we do a survey every 3 years to measure population level estimates of prevalence and other behaviors. So Zambia, like most of the world, is a heterogeneous picture. We don't see the same burden the same way in the country. So up north, we see quite a high burden, like Luapula province, which is the highest province we have. We had a prevalence of 63%. This is in children tested under 5 by RDT in the survey. 63.3% of them were found to be positive, compared to the southern part of Zambia. Only 3.3% of the people, of the children were found to be positive on RDT. I understand we'll have a discussion on South Africa, and the picture might be similar as well, with a higher burden in the north and much lower burden on the southern part of the country. So our strategic plan as a country, the strategic direction is to lower the burden in high transmission setting, to eliminate malaria in the low transmission setting, and prevent the reintroduction of malaria in the malaria-free health facility catchment area. So some of the specific objectives we have is to increase interventions from 72 to 95%, reduce the malaria incidence. We started off at 340 and we hope to end at around 201 by 2026, to reduce malaria deaths from 8 in 2021 to 4.7 per 100,000 by end of 2026. And like I mentioned earlier, we have seen some considerable progress on malaria deaths, and we haven't seen as much on malaria incidence. And also to increase malaria-free health facility catchment area from 10 to 260 by 2026, a bit similar to the goals of the global technical strategy, which is to increase the number of countries which are free from malaria. So these are some of the traditional tools that we use in the fight against malaria. So there's prevention of malaria, such as prevention of malaria in pregnancy, which is one of the interventions that we roll out in the country, where women are given sulfadoxine pyrimethamine as they look for antenatal care. Then we also have treatment of malaria itself. As a country, we've scaled up, especially on community case management. Around 20,000 community health workers are spread around the country who are providing community testing and treatment to malaria. Then we also have scaled up on indoor residual spraying. So from the previous malaria indicator survey, around 35% of households reported having had households sprayed, as well as the traditional insecticide treated bed nets. So we do mass campaigns every year. And this year in 2023, we'll be doing a mass campaign, around 11 million nets to be distributed around the country. And then we have continuous distribution channels through the antenatal clinic. Women who are coming in are given an ITN, as well as children under 5 are given an ITN. Then we also have scaled up on diagnostics. That's malaria microscopy, mostly for microscopy facilities, as well as rapid diagnostic tests, which are deployed across the country, including at the community level, where community health workers can provide testing and treatment. So there's some improved tools, the rapid testing, as I mentioned, which is at the community level, as well as in some areas of Zambia, in the low burden areas where we do mass drug administration, which has shown to contribute actually to the reduction of parasite prevalence. Moving on, there's some improved tools which are under research, like the sugar baits. This is one of the studies going on in the western part of Zambia, where we're evaluating the use of sugar baits to target mosquitoes that are outside the household. As you know, the traditional tools, the IRIS, the ITNs, target mosquitoes that are indoor, that are biting at night mostly. But the sugar bait is a trial in Kaoma, Western Zambia. We're trying to evaluate this sugar bait, which is laced with sugar and the toxin, so the mosquito is attracted there to the bait. And the thinking is that if the mosquito then feeds off the sugar and dies, then we might prevent the mosquitoes before they actually enter the household. So we're looking forward to seeing the results of this. Then on the vaccines, I think this is an exciting new space, new discussions going on. October 2021, the World Health Organization approved the first vaccine against the parasite, which is the RTSS vaccine. This vaccine has actually started being rolled out, moving on from the research mode into pilot implementation in the countries, Ghana, Kenya, and Malawi, where this vaccine was started. And recently, I think you may have followed the news, recently there's another vaccine, the R21, which has actually come on the scene as well. And the WHO is yet to issue a pre-qualification for that one. And then the future prospects are quite good, having one vaccine already approved by the WHO and the new vaccine which is coming on. So hopefully these, combined with existing tools, might actually be the game changers that we're looking forward to in the malaria space. So as I mentioned earlier on, in terms of targeting interventions, the malaria picture in Zambia is heterogeneous, like most of the world, as we saw earlier, and as we might see when we have a discussion on the burden in South Africa. So we target our interventions depending on the burden. So there are interventions that are cross-cutting, whether it's low burden or high burden. And these are listed, they're detailed in the National Malaria Elimination Strategic Plan, but I highlight some of them that we do, like case management, availability of commodities, the insecticide nets, entomologic surveillance, community case management, social and behavior change. So these interventions are cross-cutting in high burden and in low burden areas as well. For indoor residual spraying, we're targeting more on the high burden areas, as well as those areas in the low burden. And as I mentioned, targeted mass drug administration, which is prescribed for the low burden areas. Like in Zambia, like I mentioned, on the southern part of Zambia, is where we've deployed mass drug administration. In our previous strategic plan, MDA was recommended in high transmission areas, but this was changed. And as you may know, following even WHO recommendations, WHO does not yet recommend MDA for high transmission areas. This year, for the first time in our strategic plan, we're introducing Primaquine, which is a drug that prevents malaria transmission, preventing transmission of gametocytes in the low burden areas, as well as moving into active case detection, responsive IRS, and lava source management as interventions for the low burden areas. As past, our approach is cross-cutting, as I mentioned earlier on. So we support health system resilience, digital data, epidemic and pandemic preparedness, as well as innovation and access. And you have heard, we were quite involved in the development of the RTSS vaccine over 2 decades of involvement of PATH in development of the vaccine. Furthermore, PATH in Zambia supports the enabling environment, which is the context in which we do our malaria work. So we support the National Malaria Elimination Strategic Plan development of the malaria indicator survey, the treatment guidelines, the M&E plans, as well as tracking of interventions on the malaria scorecard. And so actually the Republic of Zambia won an award earlier this year as the best malaria scorecard. As the malaria scorecard, this is by the Alliance for Leaders Against for Malaria Elimination in African Leaders Alliance for Malaria Elimination, and the President of the Republic of Zambia on the right is actually receiving an award from the President of Guinea-Bissau, who's the current chair of AUMA, for Zambia receiving the malaria scorecard, and PATH provides some support to this. So finally, some of the challenges that we face on the malaria scene, like I mentioned, COVID-19 and other outbreaks, which affected, like you saw, we had so many cases coming on during the COVID-19 outbreaks. Then there's the economic downturn and inadequate financing. Actually, the World Health Organization estimates there's about $3 billion of annual spending on malaria. And if we're to achieve the targets, there's need for scale up to somewhere around $9 billion and $10 billion by the end of 2030. So you can see that there's still inadequate financing to achieve the goals. Then there's cross-border importation of cases. As I mentioned, the cases are not the same in the region. So we have an importation of cases across borders, and then reduction of the efficacy of the insecticides. This brings on challenges in terms of malaria control and the risk of reduction of efficacy of drugs. Currently, through our therapeutic efficacy studies, we still have the first-line treatment, artemether-lumefantrine, which is still efficacious. But then we've seen resistance in previous drugs that we used before, like chloroquine in most parts of the world. And then also the use of sulfadoxine pyrimethamine, which is now used only for intermittent preventive therapy. Previously, this used to be a treatment for malaria. We still face challenges in the procurement and supply chain management, especially during the time of the COVID-19 pandemic, where there was some disruptions in terms of shipments. Climate change, the projected changes in temperature, rainfall patterns also tend to affect the vectors as well as the negative consequences of economic activities and such as mining, agriculture, or fishing, which affects migrant populations, which sometimes makes it very difficult to implement those malaria interventions. So some of the opportunities looking ahead, the malaria vaccines, I think this presents a big opportunity for malaria control around the world. Then rollout of malaria case investigation. So in southern Zambia, where there's low incidence of malaria, we've adopted a strategy famously known as the 137 approach, which was done mostly in China and some Asian countries. It started from there. So where you find the case, quickly notify, quickly investigate, and then provide a response. So we're rolling out in low burden areas, and I think that is part of the end game strategy for malaria investigation. We're also trying to evaluate if we could do surveillance for malaria through antenatal care, as well as larva source management. As I mentioned, 2023, we're doing a mass campaign for the nets, and usually these contribute to a reduction in malaria incidence. And we've moved on from universal IRS to targeted indoor residual spraying, depending on the burden of the health facility catchment area. We're also doing a trial of proactive case management in the eastern province of Zambia. Traditionally, our community case management is through passive modes, where patients go to the community health worker's house. But now we're trying to try out a proactive case approach, and hopefully maybe that could also contribute to being the game changer in terms of detection. Then also we're working with the National Malaria Elimination Program in terms of developing the national communication strategy to try and improve social and behavior change in Zambia for malaria. Really, that ends my presentation, talking about the global trends and as well as the picture and some of the highlights from Zambia. Thank you.
Thank you, Dr. Puri, for that very comprehensive overview of both the global trends as well as giving us an overview of the situation in Zambia. Very excited, and congratulations to hear that Zambia was presented with that best malaria scorecard. So congratulations to you and the team and everybody else that was involved in seeing that through. It's very inspiring for all of us within the public health community to really aspire to put our best foot forward. One of the things that stood out for me as you were talking was really that the WHO Afro region accounts for 95% of the global burden. I was not aware of that statistic, and it's very sort of eye-opening to understand what that picture looks like within the WHO Afro region. I'm very excited to also hear about the trends within Zambia and to know that the malaria mortality rates are reducing within the country. Also very exciting to learn of the new tools such as the sugar baits as well as the vaccines, which PATH has been working on and has seen WHO approval in 2021. So congratulations to you and everyone else that was involved in that. I think one of the calls to action that I have heard you repeat is that we really need to be advocating for improved tools as well as innovations to make sure that we are really working towards the elimination as well as prevention of malaria by 2030. I think that's the correct date. And with that said, I would like to hand over to our next speaker. Now that we've gotten sort of a sense of what the global trends look like, used Zambia as a particular case study, I'd really like to deep dive into the South African context. And in order to do that, I'd like to welcome our next speaker, Dr. Jayshree Raman. Dr. Jayshree Raman, welcome. And Dr. Jayshree Raman is the principal medical scientist, as well as the head for laboratory for anti-malaria resistance monitoring and malaria operational research. Dr. Jayshree, welcome, and please have the floor to take us really deep into what the situation looks like in South Africa. Thank you.
Thank you so much, and thanks for giving me an opportunity to talk about malaria in South Africa. Hopefully my screen is visible to everyone. And it's really great to follow Zambia because they have done amazing things in Zambia, but they're much higher burden, whereas South Africa is a much lower burden country. So we do things slightly differently, but there are some overlaps. So in the next 20 minutes or so, I'm going to take you through where we are in South Africa. And I'm really going to focus mainly on treatment once I've spoken about the burden, because I think that's the really important for all of us that are attending today. So basically, malaria in South Africa is limited to northern east parts of the country because we lie on the southern most limits of malaria distribution. So unlike many countries in Africa where the whole country is endemic for malaria, we only have certain regions that are exposed to malaria. Malaria is very seasonal in South Africa, and we're also at very high risk for outbreaks. We traditionally have our malaria runs from September to May, and we have peaks generally after Easter and Christmas. And it's really associated with a lot of movement of people between higher endemic regions. So if we look at where malaria is, down to where malaria was, this is one of the first malaria risk maps that was drawn up for South Africa in about the early 1930s. And as you can see, malaria was found really along the border regions, but also extended quite far into Gauteng past Pretoria. And if you look in KwaZulu-Natal, it went right down to Ugu, which was formerly Port Shepstone. But we put in sustained implementation of interventions, which were primarily focused on the vector. Very much like Zambia, we used indoor residual spraying, which was actually discovered in South Africa. We started using that from the 1940s. We've also added larviciding, but unlike Zambia, we do not use insecticide-treated nets. That's not something that the government does. You can do that on a personal capacity. So very much focusing on the vector in terms of indoor residual spraying and larviciding. And then in terms of case management, when that's treating the patient, we had very prompt diagnosis using microscopy initially, added rapid diagnostic tests, and obviously we had effective treatment in place, or tried to have as effective treatment in place as possible. And all those interventions from the early 19s helped push back the boundaries of malaria. Now, malaria is really limited to the shared borders that we share with Botswana, Zimbabwe, Mozambique, and Eswatini. And it's really the three provinces, which is KwaZulu-Natal, Mpumalanga, and Limpopo. We have a very low burden compared to other countries. The burden in these three provinces is not equal. So some have a much higher burden compared to others. So if you're going to see this, I've got the malaria data here for the three provinces from 1980 to 2020. And as you can see, it has changed between the provinces. Between 1980 and 2000, the blue bars, which represent KwaZulu-Natal, accounted for most of our cases. And after 2000, the orange bars have risen to 4, and that's Limpopo. So now Limpopo accounts for most of our cases, whereas pre-2000, it was KwaZulu-Natal. A closer look at our case burden shows you that we've had upsurges in cases. And in the 80s, it was primarily the upsurge was seen in KwaZulu-Natal, and that was driven by the parasite becoming resistant to chloroquine. And that forced a change to sulfadoxine pyrimethamine. And thereafter, we had a major upsurge in cases in 2000, and that was driven again by resistance. But in this case, we had resistance to the drug. The parasite had become resistant to sulfadoxine pyrimethamine, or Fansidar. But the mosquito had also become resistant to the pyrethroids that were being used for insecticide resistance. And added to that as well, we had very, very heavy rains and floods in the KwaZulu-Natal, Mozambique area. So that really created the ideal breeding grounds for mosquitoes. So we had a real uptick in cases. And then KwaZulu-Natal became the first area in Africa to put in an artemisinin-based combination therapy. So they became the first area to introduce artemether-lumefantrine. PT had to be reintroduced for vector control in terms of IRS. We saw a decrease in cases across all three provinces, and that decrease continued. And then in about 2007, when we had a major decrease in cases, South Africa started talking to the WHO about actually moving from controlling malaria, where you actually just try to control your case burden, to moving to something that is known as elimination, where you are trying to stop the local transmission of malaria. So you're trying to stop mosquitoes being infected in country and then biting somebody in country. And South Africa officially transitioned to an elimination agenda in 2012. We had an upsurge in cases in 2017. It was the first time in a long time that we had an upsurge in cases that was not driven by resistance. It was driven by climatic changes. Again, we had a major unexpected heavy rains, so we had a much wetter season, and there were some system failures. But again, after that, we've managed to go down again, and it looks like we are progressing towards elimination, but we haven't quite achieved elimination as yet. Just to quickly touch on our elimination agenda, we're currently in our second elimination strategy, and it's due to end this year when we were supposed to have stopped local transmission. Obviously, we haven't. The COVID pandemic has played a major role in that, but we are making progress, which is something positive. So we will be doing our next elimination strategy, and hopefully we get much closer to being able to eliminate malaria. I'm sorry, I can just see something's come up on my screen, which I just need to get rid of so that I can move forward. Sorry about that. All right. I just want to touch on something that was brought up in the last webinar, last talk, which was talking about being in a high burden country where people get repeatedly bitten and then you will develop some level of immunity. So in areas where you get a lot of mosquito bites, which are high burden areas, so for example, the northern regions of Zambia, children are going to be bitten repeatedly. And if they survive that, they develop something that is known as partial immunity. So that does not prevent you getting infected, but what it does prevent is getting severe symptoms and severe disease. So that they will become what is known as an asymptomatic carrier. So they will have malaria, but they show no signs and symptoms, and they can live, carry on quite normally. In South Africa, we do not have that repeated exposure to malaria. So our entire population is non-immune, which means that everyone is at equal risk of getting malaria. So we don't have high-risk populations as high burden countries would be children under 5 or malaria pregnant women. They still are at risk, but they are as equal risk as the rest of the population. And because we don't have immunity, people in South Africa will generally show symptoms within the 10 to 15 days after being bitten by mosquitoes. But that is also a challenge when you're trying to eliminate malaria. So if you are somebody that has no immunity, you are going to show signs and symptoms and you are going to go to a healthcare facility. Whereas if you are somebody that has some level of immunity, if you are bitten, you are going to become asymptomatic and you're going to show no signs and symptoms, which means you are still going to be able to control malaria if you get to the infectious period of time, but it's not going to be something that you're going to target and control. But in elimination, what you do want to be able to do in an elimination phase, which South Africa is we want to be able to catch all of those that are presenting at healthcare facilities, that's passive case detection. And we also want to catch anyone that might be crossing the border that has some level of immunity that is not showing any signs and symptoms, because they could infect mosquitoes and we could have local transmission. So that's a little bit of the challenge that we have in South Africa, is that we have to be able to capture people that have signs and symptoms as well as those that don't have signs and symptoms, to make sure that we don't have any onward transmission. So now I'm just going to talk about our guidelines and what we say specifically in South Africa. So for South Africa, malaria, you cannot do presumptive diagnosis. Before you can treat anyone for malaria, you should have a confirmed parasitological test. And our guidelines recommend that it's done either by microscopy or rapid diagnostic test. We do not rule out PCR. It's not something that is recommended in our guidelines, just because primary healthcare facilities do not have access to PCR or any other molecular testing, but it's not something that we do not, we just haven't recommended it in our guidelines. Because most of the cases in South Africa are due to falciparum malaria, the RGT that is recommended in the public sector is a falciparum specific rapid diagnostic test, and it targets the antigen that is produced by the falciparum parasite known as the histidine-rich protein 2, or the HRP2 gene. And currently, the first response HRP2 falciparum specific RGT is used in the primary healthcare facilities across the endemic regions. It's also really important to note that in South Africa, malaria is a category 1 notifiable medical condition, so that it requires all medical practitioners that confirm a malaria case to notify within 24 hours, and it's going to be notified on the notifiable medical conditions form. So you've got an example on the form on your screen, or you can do it via your app. And it's really important to notify, because particularly in the malaria endemic areas, within 24 hours of a case being notified, it needs to be investigated. And that is to be able to find out whether the case is local or imported. And that informs the activities that the malaria control program follows. And it's really important that when you are filling out, whether it's the app or the form, you fill in as much information as possible, particularly on the signs and symptoms, the treatment, and the travel, because the travel helps guide the way the case is going to be classified as local, as imported. And that is really critical as we move towards elimination, because when the WHO comes to certify us as having eliminated malaria, we need to be able to prove that we have actually stopped local transmission. If using RGTs, now these numbers are very specific for the first response RGT, but it is valid for any make of RGT that you use. If you are going to use the RGTs for rapid diagnostic testing of malaria, you should use it according to the recommendations guided. Deviating from the recommendations in the leaflets increases your risk of getting an incorrect result and possibly diagnosing somebody with malaria with negative consequences. Just some basic guidance: if you are doing rapid diagnostic tests out in the field or in areas that it's really very warm, it's really critical that you ensure that you keep your rapid diagnostic tests and your drugs in as cool as possible. This is when you're out in the field, but do not store your rapid diagnostic tests for prolonged periods in temperatures lower than 10 degrees. That definitely does affect their performance. There's something that we've implemented in the endemic areas, which is where we are trying to do QA and QC on the rapid diagnostic tests. So we ask them some basic information on them, which is the connect code, the date this was done, the date of birth of the patient and the patient's initials. And that is if you are sending the test to the NICD for testing to confirm that your rapid diagnostic test is working as correctly. And I'll explain why we put that in. So again, there are just some issues with using rapid diagnostic tests. Like I said, it's really critical to make sure that you read it at the right time. Reading it too early or too late increases your chances of getting an incorrect result. Rapid diagnostic tests are very much like baking a cake. If you add too much or too little of the reagents or the that are supposed to be done, or too much or too little blood, you are going to get the incorrect results. So you definitely have to make sure that you abide by the rules. Adding too much blood dilutes your, adding too much of buffer dilutes your blood, which increases your chances of getting a false negative. There's also something to just note that if you're using rapid diagnostic tests that are falsification specific and target the HRP2 gene, that it should only be used for initial diagnosis and not for follow-up. Just because the HRP2 antigen stays in circulation, even if the infection is cured. So if you're testing a patient within 4 weeks of being treated, they're most likely going to come up RGT positive, and you will think that they are malaria positive when they're not. It's just that their antigen is still present. So if you are wanting to check a patient to assess cure, then you'd have to use a different make of rapid diagnostic test, PCR or microscopy. The other challenge with using HRP2-based rapid diagnostic tests is that the parasite has evolved a mechanism to evade detection. So what it has done is has some mutations in the HRP2 gene, which makes sure that if you are testing a patient with malaria and if they have these mutations in the HRP2 gene, they will not be detected by the rapid diagnostic test. So you will send a patient that is malaria positive home saying that they do not have malaria. While it is quite prevalent in certain areas, it started in Southeast Asia and has spread to certain regions in Africa. This is the recent map, threat map from the World Health Organization, which maps all the areas that have reported the deletions. As you can see in Southern Africa, the deletion is very rare, so you can still use HRP2-based rapid diagnostic tests to test anyone that comes from Southern Africa. But you really should be aware, if you are testing people that come from Central Africa, Rwanda, Uganda, the Horn of Africa, that they might have this deletion, so you might have to use a different rapid diagnostic test. Right, we have heard that there are two forms of malaria. You get uncomplicated malaria and severe malaria. And based on the different type of malaria you have different treatments. So I'm just going to go through what we recommend in South Africa. So in South Africa, for uncomplicated malaria, the treatment that is recommended, our first line treatment is artemether lumefantrine, or commonly known as Coartem. It is given on a weight-based schedule for children and individuals weighing more than 5 kilograms upwards. It is absolutely critical and essential that you make sure and you recommend that all people taking the drug take the drug with some fat. And that is just because it is really essential for the optimal absorption of the drug. If you don't take that amount of fat, your absorption is reduced and your chances of absolute cure are reduced. We have noticed that if people weigh more than 100 kilograms, that the standard dose, the standard three-day dose, may not be as effective. So in our updated guidelines, which came up in 2019, we did recommend that people start considering that for people over 100 kilograms, the dose is stretched from 3 days to 5 days so that they get 10 doses, and that just increases the absorption of the drug. When given correctly and taken with 1.25 grams of fat, there is rapid cure with artemether lumefantrine, and within 3 days, you could theoretically not being able to see any parasites in a blood smear. To date, there is no evidence of resistance in South Africa, but critically, surveillance is very, very important. And the reason that surveillance is really very important is that we have confirmed parasites that are resistant to artemether, the component, artemether component of artemether lumefantrine in Rwanda, and it has since spread to quite a few other countries. So we've got confirmation now in Eritrea, Uganda, Tanzania, and possibly Ghana. Also, what's adding a little bit of concern is the surveillance that is conducted by the NICD. Is while we haven't found the mutations that are associated with directly with artemisinin resistance, what we are finding is that the parasite is having mutations around the area where there are very important mutations associated with drug resistance. So it's really, really critical that if you have a patient that possibly fails treatment first off, you do send the sample through to the NICD to be assessed for drug resistance so that we can make some recommendations and also put some containment efforts in place. But also, because we are really concerned about drug resistance coming to be a huge problem in South Africa, and as we've seen in the 1980s as well as 2000, it really did cause an upsurge in cases. What we have done for case management is implemented intervention in all the eliminating districts of South Africa, which is known as smart surveillance for malaria elimination. What we require is that all healthcare facilities in the eliminating areas collect the rapid diagnostic test, the positive rapid diagnostic test, also collect the blood spot, and together with notifiable conditions is sent to the NICD. We analyze it for drug resistance markers that are associated with resistance to artemether as well as lumefantrine, and then we map it down to facility level. But also what this allows us to do is that if there's any increase, if we do pick up any mutation of concern, we can localize a response and have the program to a containment intervention as well as a really good response, either changing the drug or doing some other intervention to make sure that the resistance doesn't spread. So just another group that I really want to highlight is malaria in pregnancy. Given the risk to both the mother and the unborn fetus, malaria in pregnancy must be regarded as a medical emergency. According to our treatment guidelines, we haven't said that any person that is pregnant and with malaria should be put into hospital, but they must be treated as a medical emergency and given the best care as possible. Standard artemether lumefantrine treatment is recommended for all trimesters for uncomplicated malaria. If they have complicated malaria, which I will discuss just now, but IBR testionate is definitely recommended. In terms of chemoprophylaxis, which I do know in the next talk they're going to discuss, mefloquine is the only drug that we recommend in our guidelines. We do know it's very difficult to get, and the safety of any other products is unclear. So our recommendation in the current guidelines is if a pregnant person doesn't have to travel to a malaria endemic area, then they shouldn't. Severe malaria, and this is really, really very important. The preferred treatment is IBR testionate. It has been registered to 2017, so there's no need to get Section 21 approval. Because it is a significantly better drug than IBR testionate, it should be used whenever possible. If severe malaria is detected at a primary healthcare facility, the person must be referred as soon as possible to a facility that can administer IBR testionate. If there's delays, then the person, if is able to swallow, should get a dose of artemether lumefantrine. And if they have access to intramuscular artesunate, they can also get 1 dose of that. Once at a tertiary facility where they are giving out artemether, where they do give out IV artesunate, the individual must get at least 3 doses of IV artesunate, and then must, once they are able to swallow and out of a coma, they must be given a full dose of artemether lumefantrine to ensure full parasite clearance. And then one of the final interventions that we have implemented in South Africa, which, as Zambia said, they have started doing. We started doing this in 2018 based on the recommendation from the Global Malaria Program, was including single low-dose primaquine. And this is a transmission blocking drug. We did a clinical trial in South Africa to generate safety data for it. It was proved to be safe. So we have got special permission, Section 1 permission from SAHPRA, so that in the eliminating areas, single low-dose primaquine is added to standard treatment to anyone that is found to be malaria positive, and it is going to be transmission blocking and therefore hopefully helping to stop any onward transmission. The low dose of primaquine is not associated with increased risk of hemolysis in people that have G6P deficiency. And there's just a few people that shouldn't get it just because we haven't got any clear signal yet whether it is detrimental or safe to them. And that is any individual that is pregnant or breastfeeding or infants under than 6 months. And hopefully if we add these interventions to all the others and we do this correctly, we can get closer to being able to draw the line against malaria in South Africa, can eliminate malaria by 2030. Thank you very much.
Thank you very much, Dr. Raman. I don't know about the rest of the participants, but I definitely will not forget that rapid diagnostic tests are like baking a cake. So please make sure that you're putting in the right amounts of the ingredients to make sure that you have the perfect outcome. And thank you so much for providing that context for South Africa. I think it's really great to see that South Africa is making progress towards the elimination strategy, but also for sharing South Africa's guidelines around diagnostics, such as the RTDs and the microscopy, and some of the sensitivities around temperature is one that I picked up, and really a focus on both treatments for complicated and uncomplicated malaria, with a very strong focus on our pregnant women. I think it's quite critical that you have shared that with us in some of those smart surveillance systems that South Africa has put in place. And I think it's interesting to note some of the challenges and the shift in changes from KZN being one of the more high burden disease provinces and seeing that shifting more to Limpopo. So really great to hear some of the perspectives from the country. And if anyone has specific questions for Dr. Raman, please do pose them to her in the Q&A. With that being said, I would like to hand over to our SAHPRA colleague, who is Luleka Dlamini. Luleka, please take us away and share some of the approved health products that have been approved by SAHPRA to combat malaria.
Thank you so much, Taonga, and good morning to everyone that is attending the webinar. So I will be taking you through just some of the products that SAHPRA has registered to combat malaria. Mostly on our case, it's really a prophylactic medication and the treatment that is available on the market. I'm not sure if you can see the slides. Please confirm, Taonga.
Yes, we can. Thanks.
All right. Thank you so much. And yeah, to start off the presentation, we are just going to highlight what the mandate is for SAHPRA. But I think our colleague Dion has already touched on this. But you know, just to put an emphasis, we are tasked as a regulator to monitor, to evaluate, investigate, inspect, and register all health products, including you know, overseeing clinical trials, complementary medicines, medical devices, and in vitro diagnostics. And in that, we operate and we are governed by the 3 pillars which are safety, efficacy, and quality. But over and above that, because we do regulate medical devices and IVDs, they must be of high performance. And I think Dr. Rahman has touched on this slide that talks to the endemic areas in South Africa. So I'm not going to delve much on it, but it's just to highlight that, in South Africa, this is mostly a traveler's disease. So it's more endemic in particular areas as opposed to other, inland areas in the country. And available for prophylaxis. We have non-pharmacological preventative measures, and those, I think a lot of people already know about this because it's what is mostly spoken about, the use of mosquito nets, wearing long sleeves, the aerosol insecticides, and all of those things. But over and above that, as a regulator, what we have registered is the use of mefloquine, which this product, I think Dr. Rahman has touched on it, that is also a product that is safe for prophylaxis, also even for infants and pregnant women. And then you take this a week before you enter the area. You continue the treatment while you're in the area. You continue once weekly for 4 weeks after you leave the area. And then we also have registered the doxycycline, though contraindicated in patients that are 8 years and below, but you administer it once daily, 1 day before you enter the endemic area, and you continue with treatment while you are in the area, and you continue with treatment 4 weeks after leaving the area. We also have registered the atovacone and proguanil combination, which you take 2 days before you get into the malaria area. You continue with treatment while you are in the area, and after leaving the area, you continue with the treatment for 7 days. But with this, the choice of regimen really depends on patient factors, which are age, whether you are pregnant or you are breastfeeding, other medical conditions, if you have epilepsy or depression, what other medications are you taking, so that we avoid issues of drug-drug interactions, and activities such as scuba diving or flying. And these really are conversations that you have with your health worker at the point of taking the medication, so that you don't find yourself in a position where we are dealing with adverse drug reactions. And then because we know that prophylaxis is not always 100% effective, we do have registered a treatment, the combination of the artemether and lumefantrine. I think Dr. Rahman touched mostly on that, because I think it's the first line treatment for malaria in the country. And this, she's already mentioned that it's the dose is weight dependent. And then we have registered also quinine, which can be used with the doxycycline, although this combination is only available for patients where the combination of artemether and lumefantrine is contraindicated, or it's not available. And that also is contraindicated in patients below 8, because the doxycycline you can't use in patients below 8 years. And then we have quinine also that you can use with clindamycin. This is applicable for patients infants that weigh less than 5 kg, and pregnant women that cannot, in the event where the artemether lumefantrine cannot be taken, because that is a drug of choice also in pregnant women. And then we have registered chloroquine. I think the issue of resistance that the previous speakers have spoken to applies mostly to the chloroquine. And I think that's why you wouldn't necessarily find it as a treatment of choice, but we do have it available in the country. And also we have registered the artesunate, and I think Dr. Rahman has indicated that we registered this product in 2017, and that we use to treat a severe or complicated malaria, and it comes in an IV form. And then also, we do have the Primaquine, even though it's not registered, but it is available through Section 21. And this is a product that we approve on an inpatient basis, and it's dependent, sorry about that, it's dependent, on an inpatient basis, and it will be the responsibility of the prescriber to ensure that the patient is able to access this medication. And then in conclusion, we are saying that South Africa is striving to be a malaria-free country. And as a regulator, we have a responsibility and a role in ensuring or being an enabler to access of safe and efficacious health products that are of good quality. Thank you.
Thank you, Luleka, for your perspectives and in particular sharing some of those prophylaxis options as well as the treatment options for malaria within South Africa. I'd like to see if there are questions for our panelists, and maybe it'll be nice to have our panelists come off their put on their videos just to have this conversation with some of the questions that have been posed by our participants. We have a couple of questions here. I think some of them are for our SAHPRA colleagues. And this one is from Lindsay Smith-Bossett, who says, in the light of malaria, what is being done with regards to unregistered insect repellents in the market, some with active pharmaceutical ingredients that may be new entities and may be dangerous to the health and safety of the consumer. So she is particularly interested in unregistered insect repellents in the market. If any of our SAHPRA colleagues have an answer for that, I will ask 3 questions, maybe in a row, and then we can take it from there. The other question is from Karen Barnes, who says, given the small market for malaria treatment in South Africa, could you please comment on the role of Section 21 approvals to access unregistered anti-malarial treatments? So that is Section 21 approvals. The previous one was unregistered insect repellents. And then there's another question from Johan Eus, who says, can infant be given anti-malarial drugs? So those are the first 3 questions I'll let our panelists respond to, and then time permitting, we can choose another 3 to respond to. Over to any one of our panelists that would like to respond to those questions. Thanks.
Thank you. I'll take the Section 21 question. I believe it has been answered partly by my colleague Luleka, but there is a role for Section 21 approvals when it comes to drugs, for example, like primaquine, which she has mentioned. So there is a role for the Section 21 process in making sure that drugs like that are made available on a named patient basis.
Thanks, Diana. I also see related to what you have said on primaquine, there's a particular question here from Melissa Munguma, who's asking if primaquine, let me just read the whole question. South Africa, malaria cases are decreasing and appears the country would benefit from the use of primaquine as an example. Does SAHPRA foresee registration of primaquine in the near future to move away from the need for Section 21 application? I think that's it's directed at Dr. Raman, but Dion or Luleka, if you are able to respond to that, also please feel free to come in.
I'll ask Luleka if she can talk to that part. Thanks.
Okay, thanks, Dion. I think we are foreseeing a future of I mean, at the end of the day, the country is seeking to be a malaria-free. So we can't be a barrier to access to such products that can potentially prevent transmission. As we were saying, that this is a traveler's condition in our area. So we can't necessarily stop people from traveling. So we are saying we want them not to be transmitting the condition as they are traveling to South Africa or even to other countries. So we are foreseeing a possible future for us to register the product.
Thanks, Luleka. I hope that answers your question, Melissa. There was another question around infants and whether can infants be given anti-malaria medication.
Yes, they can. Again, it's just dependent. I will let Luleka jump in a minute, but also it just depends on their weight and if there's anything else. So there, it really depends on weight and which drug you're wanting to give. But I'm going to hand over to Luleka to answer this more.
No, I wanted to say the same thing, Dr. Rahman, because we did highlight the choices that we have. So the use of mefloquine, for instance, in infants that weigh over 5 kg, you can use that for prophylactic use. You can also use quinine with clindamycin in infants for treatment.
Thanks, Luleka. I see some of the questions have been answered by our panelists in the Q&A, but maybe it would just be good to verbalize those. Dr. Rahman, there was a question here which said, which RTDs are most used? And someone, Alexandra Kryatova, wanted to know if this was specific to Alera by ABOT. Are you able to verbalize the response that you provided here?
Sure, absolutely. It depends on where you look. So in the private sector, because it's not regulated, you're free to choose whatever you want to use. So there's any make of RD to use as long as it's, it's approved in country. Within the private sector, within the endemic area, the public health, the primary healthcare facilities are recommended to use the first response RDT, which is an HRP2 falciparum specific. Within the NHLS labs, they use a different brand. So it really differs, and it depends on where you look. As long as it meets the requirements of having a certain percentage of sensitivity and specificity, you're going to do okay. Hopefully that answers the question.
Thanks, Dr. Rahman. There's also a question here from Mama Flo Makuba, who's interested in traditional medical products. And this person is wanting to know if there are any traditional medical products, whether it's in South Africa or in Zambia, that are registered or not registered, or elsewhere in the world that can be used. And this also notes that not allopathic. So anybody would like to pick this one up? Traditional medical products.
I think for South Africa, we are not aware of any complementary medicine that has been registered for the treatment or even for prophylaxis of malaria.
Thanks, Luleka. Any perspective from Zambia, Dr. Puri?
Yeah, we have a similar perspective from Zambia as well. We do not have any traditional medicines registered for the treatment or prevention of malaria. And our treatment guidelines are quite similar to the South African ones. I followed through, it's exactly the same treatment guidelines. Thank you.
Okay, thanks for that response. I hope it answers your question. Let me see what other questions we have open here. This one is from Karen Barnes, and it reads, in infants, artemether lumefantrine, an injectable artesunate, followed by artemether lumefantrine, preferred for the treatment of uncomplicated and severe malaria, respectively. Okay, this doesn't seem to be a question. I think it's more of a comment, because it also says quinine plus clindamycin only second-line treatment. So I'm not sure what the question is here specifically, but it does seem as though it's more of a general comment. But if anyone would like to come in on that, please feel free to respond accordingly.
Prof. Barnes is just responding to the question on infants, and it's just giving the treatment that should be given to infants there.
Okay, all right. Thanks, Dr. Rahman. There's also a question here for you, Dr. Rahman, and whether you could clarify more on the treatment course. And I think it's the same thing for artemether lumefantrine, and you had lumefantrine, in adults. And I think you were starting to give a response on it. And would you please be able to verbalize it a little bit more for us?
Was that, sorry, I missed that. I was just looking at the question. So which one were you asking?
No problem. This was on clarity, more on the treatment course for artemether lumefantrine in adults weighing more than 100 kilograms.
Okay, sure. Yeah, that is something that is coming up, and it's been a recommendation, but I think it's going to get a little bit stronger. So what we're saying is the standard dose for artemether lumefantrine at the moment is a 3-day dose, over with 3 days with 2 doses per day. What we is recommending for people that weigh over 100 kilograms is that you extend it to 5 days. So you just have 2 doses per day, but you take it to 5 days, so they get 10 doses. That's all we're recommending.
Thanks for the clarity, Dr. Raman. The question around the unregistered insect repellent seems to be coming up again, and on active pharmaceutical ingredients that may be new entities and may be dangerous to the health and safety of consumers. Would anybody like to take a shot on unregistered insect repellents in the market and what is being done with regards to that?
Thanks. I think I'll ask my clinical colleagues to maybe just come in terms of, what is being called up and what actually is registrable. And then I will come in terms of law enforcement and control. Thank you.
Okay. Thank you. With regard to the unregistered insect repellent on the market, there was a call up, I think in 1975, for all the insect repellent that are not registered to be registered. And however, since the inception of the Cosmetics Act and the Complementary Act, this is where now there was a little bit of overlap between the 3 acts. And then this is where, in terms of that call up, SAHPRA is still reviewing the call up, because we now have to define where the insect repellent falls in, whether they fall in under the complementary medicine or they fall into cosmetics, because you can remember some of them, if you were to look at all the insect repellent, some of them you do apply them on your skin and some not. And so we need to define exactly what is it that we would consider as a medicine that we can register, and then at what quantities. So this is where we are in terms of those. Thank you.
Thanks. And then based on that determination, we will then provide further action and guidance to the industry in terms of, what can be put on the shelf, and in terms of also claims, what you can claim this product to do. But it all comes from that, as you said, the overlap that Mahlodi was talking about, that SAHPRA needs to further define and clarify the waters. Thanks.
Thanks, Mahlodi and Dion. I think this is the last question that I have on my side, and it's from Johan Eers, and he's wanting to know if you can get a malaria relapse after months or even years with no symptoms. So I'll open that up to anyone that would like to respond. Can you get a malaria?
I'm just going to take the first shot on that. So yes, you can. If you have the relapsing malaria that hasn't, which is going to be your Vivax malaria or your Ovali malaria, and if you still have that liver stage and that hasn't been cleared with a high dose of primaquine, so that is possible. And those generally happen after months. It's rare years, but there have been instances where it comes out after years. So it is possible.
Thanks for providing
Not
that.
sure if Dr. Curry wants to add anything.
Thank you, Dr. Raman. I had exactly the same answer. It's for Plasmodium vivax. That's where we see the hypnocytes. Yeah.
Thank you both for providing that clarity. We have about 5 minutes left, and maybe as we wrap up, I can give an opportunity to each one of our speakers just to give 1 or 2 sentences in closing up, maybe just starting from the order in which we gave our presentations. Mr. Dion, if you have any few words, and then Dr. Webby, Dr. Raman, and Luleka.
Starting with me.
I beg your pardon?
Are you starting with me?
Yes, please. Or any.
No, I just want to say, I think this is an excellent initiative. Just to get everybody's views around malaria, just to understand what everybody's doing around it. I mean, we all do our little part, and we don't think about the impact that it has. and we don't seem to think about what other people are doing about it. So it's nice that we all got together and seeing that we're all taking this from different angles, but all going in the same direction. So great initiative. Thanks.
Thank you. It's really been wonderful to be a part of the webinar and also learn what is happening in South Africa. South Africa is some steps ahead ahead of Zambia. So some of the programs that are being implemented in South Africa are some of the programs we'll implement in Zambia in the lower burden areas. And also just to share our hopes together that we can really reduce malaria by 90% in 2030, especially with the vaccines that are coming up, which are giving us a new glimmer of hope. Thank you.
Thanks. I echo everyone's sentiment that I think this was a fantastic webinar. We all got to hear what other things people were doing. We got to hear what was happening in Zambia. We also got to see the progress. And just as my plea is that we all take malaria seriously and that we all get to make the reality that we can live in a malaria-free world soon. Thank you.
Thank you. I think, yeah, I echo the sentiments that have been shared as well. We've learned quite a lot from particularly the Zambian presentation, you know, especially because they're highly burdened with malaria. So it's quite interesting to see the initiatives that they've taken to combat this disease. And, you know, together we can absolutely do more and combat malaria in our respective areas. Thank you.
All right, so I'd like to take this opportunity to thank you, all our speakers, for taking time out of your busy day to really come and share your experiences and perspectives with us. I'd also like to take an opportunity to thank our SAHPRA colleagues for bringing all of us together to be able to have this conversation. And if you would like any further information, I think several people have been asking if this presentation or this webinar will be shared, and the answer is yes. Our SAHPRA colleagues will be happy to share that presentation with you. And once again, we look forward to working together to make sure that we reduce malaria by 90% by 2030, as has been already reiterated. So thanks to our participants. Most importantly, it's always a pleasure having the opportunity to be able to have these conversations with you, and we appreciate your participation and look forward to also engaging with you further in the future. Wishing you all a very lovely rest of your day. And please keep in touch and let us know if there's anything specific you would also like SAHPRA to have a conversation on in the near future. So thank you from all of us here, and have a great day, everyone.